Thank you for joining us today for our discussion on the application of large language models in healthcare, opportunities for innovation. There is so much happening in this space and it's changing as we speak. I'm Nikki McManus, member of the HBS Healthcare Alumni Association Board, and I'm here with Dr. Trishan Panch, president of the Harvard T.H. Chan School of Public Health. We're collaborating again today across our respective alumni associations. This is the 5th event in the series. The last 4 events can be accessed on YouTube. Trishan will share links to these in his materials later if you haven't had a chance to watch them. Today, we're bringing together our expert panelists to talk about the progress made in implementing large language models in healthcare and opportunities to advance this. On the logistics front, thanks to Mariella Boudreau, David Rogers, and Susan Calcio, the rest of the team behind the scenes. We will have time for questions after we hear from the panel. So please type those in the Q&A, not in the chat. We'll get to as many as we can. The session is being recorded and you can find information about our other upcoming programs on both of our websites. So over to Trishan to introduce our great panel of experts.
Hi, thanks so much. So guys, we have a little bit of an issue in that the host has disabled screen sharing here. So if you wouldn't mind undisabling that, I'll be up and running with the slides in a second. But as Nikki said, thank you, Nikki. Thank you, Marielle. Okay, great. So you guys can see my background, right? I'm assuming there's a thumbs up there. Excellent. Okay, so I'm going to go through quickly some just a little bit of kind of scene setting here. So as Nikki said, I'm president of the Alumni Association here at HSBH, and we do this joint event. We've been doing, this is the 5th in the series actually, which first started as just a conversation between some of our friends, but we have had all of these organizations represented in some way or another, and a number more from the excellent panelists that we've got today. And the reason we're excited about this is that we're in a very, very, very interesting time. So since we spoke around about a month ago, and these slides will be available afterwards. They're just really a kind of aid. Lots of people ask me after the last ones, could they have them? Because we went through some kind of foundational things, but this is not meant to be a lecture. We're going to get to the discussion quickly, I promise you. So we've got these, these foundational models that I think everyone has heard of. They've certainly heard of GPT. Palm is Google's one. These are kind of foundational models. I think the way that I certainly think about them is, like iOS and Android are for like mobile phones, an operating system with an app store that other people can build last mile or first mile solutions, whichever way you want to put it, that realizes the value of these powerful technologies in consumer applications and enterprise applications. I think everyone's broadly aware of that now. Now, the organizations that have come up with these powerful technologies have also now implemented them on their existing product surfaces, which are at massive scale. And so they're doing it in beta form to start off with. So we have in search, in Bing and in Google search, in beta form. I've got a few things from playing around with that. And then on the kind of the productivity solutions, Office, Microsoft 365 and G Suite. And I'm sure many of you that are watching this will have seen that over the last few days. Also, we've had a massive reduction in the cost of using the API, the cost for other developers to use these technologies within their own applications. That's occurred again in the last month. And then just yesterday, we had GPT-4 released, and I've had a chance to play around with the text version of that over the last week or so, and I'm going to share some things. Crucially, interestingly, reports are it passes every standardized test. We're going to go into a little bit about some of the medical things there. But of course, there's prevalent concerns. And in this panel, we had one professor last time. We now have 2 computer science professors. And we're certainly going to go into some of the implementation issues, some of the reasons to be excited, but also some of the reasons to be concerned. Some of those were covered, those of you that read the New York Times, in an article by Noam Chomsky, I believe it was last weekend, or could have been weekend before. These slides are going to be available, so I'm not necessarily going to have the chart, I'm not going to read through them directly, but on the right is Prometheus, which is the text form of GPT-4 with some other controls around it. This comes from Sebastian at Microsoft, so I didn't do this one, but this is the GPT-4 powered response to what were the assertions in this editorial about the limitations of this kind of model. I would strongly, strongly recommend reading it when you have a look at the slides, because there's some very interesting logical reasoning with citations here that I think you might share that reaction with me after you read it, but please do so and get back to me later. I ran the same thing. This is Prometheus in Bing, just the search engine. It's in beta form, so it's a testing thing, but this is basically from the MedQA dataset, USMLE questions. The answer is correct, but also the reasoning is really interesting and entirely kind of logically coherent. Again, another one. This is another general medical question put in. Again, I'll leave these for you to play around with. Those of you that have access to GPT-4 can recreate it yourself. The MedQA dataset is on GitHub and free to do so you can try your own. But these are very, very powerful results. And I've run through this with a number of different clinicians in the last few days. And the reactions are as interesting as the content. So anyway, that's going to be a rich area for discussion. So here's some of the discussions here's some of the things I've heard from other people who've been testing this out. So this is a non-human, superhuman form of intelligence. This is not AGI. So I'm not going to cite the people directly because I think it probably would, there are reasons not to do that, but these are real quotes. This is not AGI, artificial general intelligence. If this is not AGI, sorry, then it is glimmers of AGI. Now, it's a very loaded term. It's a strong statement. Anyone working in a tech company is not going to want to necessarily be dealing with the secondary consequences of saying things like this, but these are things being said. Compared to Prometheus, ChatGPT is a toy. Do not use it in any serious applications. Again, this is just today from Alan Karthikesalinga. I think we'll try and get on the next one. This is the previous benchmark of using these models in the USMLE. They published a paper, I believe it was like 2 months ago or so, and that benchmark has been exceeded again. And they say that this is over above expert level performance. And so we haven't seen the paper, but that will be coming soon. I'm sure Suchi and David have strong opinions here. There may be some reasons that AGI, what does it mean? Why is that a crazy thing to say? I've left some ideas here. You can refer to them afterwards, but that's just to avoid us having to get into a philosophical discussion here. Okay, the panelists. So I hope they don't mind. They probably do. But I took the photos that this amazing group of superheroes that we have assembled kindly shared on the HBS website for this panel. And we did a bit of generative stuff. And we have Nikhil, David, Emily, Suchi, and Gaurav, the panel, and we're going to get right to it. I hope they don't mind the use of their photos in this way. I think we can also see some of the biases of, I use Midjourney, so I'm blaming it on them, the way they've rendered these things as well, but also, it's playful. So anyway, so to kind of get straight to the chase, I am just going to ask people, if you don't mind, to introduce yourself. We can stop the screen sharing now, so I'm going to basically stop that from here and we should go back. Great. Okay, we haven't lost anyone. Okay, so I'll just, if you don't mind, I'll just go through in just order that you're on the screen. So Emily, if you wouldn't mind just saying hello first.
Sure. Emily Melton. I am a founder and partner at Threshold Ventures, which is an early stage venture fund that invests in the intersection of technology and healthcare. I am also like the least intelligent nerdy person, so I feel like I should be the brawn. Instead, my superhero made me look like the brain. So I don't want that to set up false expectations for this discussion.
Well, that's not true. I mean, we are all here to learn. Everyone is working out as they go along, of course.
I'm the only one here without a PhD. Let's just levels.
Well, that's also not true. Okay, Suchi.
Hi, everybody. Hi, everybody. Trishant, thanks for having us and for a fun fifth convo on the topic. I am founder CEO of Bayesian Health, which is a health AI platform company working on augmenting frontline caregivers with AI driven for multimodal AI. I'm also an investment partner at AIX Ventures, which is a leading seed pre-seed AI-focused venture company and is formed by actually other experts in the field. So it's really, really fun. And the last 12 months, obviously, I mean, I think it's been a very fun 10 years in AI. Yeah. It's just felt more and more sexy, I guess, in the press in the last few years. And then I also hold an endowed chair, and I'm a professor in AI across engineering, medicine, and public health at Johns Hopkins. And in that capacity, also work with the FDA on a lot of research around AI regulation.
Thank you, Suchi. Thanks so much for joining us. It's great. Gaurav?
Hey everyone, thanks Trishan for having me. My name is Gaurav Singhal. I'm a physician and computer scientist by original background. Spent many years at Foundation Medicine, a cancer genomics company, as their chief data officer, building a data platform around cancer genomics. For the last 3 years or so, I've been an advisor and investor in a couple dozen companies across health data and tech. And I still see patients a few weeks a year as a member of the Harvard faculty. So great to be here.
Thanks, Gaurav. Thanks for joining us. David?
Hi, everyone. Good to see everyone again. I'm David Tantag. Let's see.
You've been blurred out.
Yeah. Why don't you go to someone else? I'll come back in a second.
Okay, cool. Yeah. Nikhil?
Sure. Well, I love the photographs you shared. And what's the use of AI if it can't make me actually look like that? So name is Nikhil Bhojwani. I'm a managing partner at Recon Strategy, a healthcare consulting firm that I co-founded, 12 years ago, having spent many years at the Boston Consulting Group before that. Obviously, as a strategy consultant in healthcare, very interested in the impact of AI and have been following it for years. Trishan and I have written quite a bit about business use cases of AI in healthcare. The thing that really excites me about LLMs in particular is this. So my job is largely creating content. And what happens when the marginal cost of creating content goes to zero? And it's scary, it's exciting. And what's that going to mean to business models? And so that's really my focus, is business models in healthcare. And hopefully we'll touch on that a little bit today.
Great. Okay, David.
Yep, so I'm David Tantag. I'm a professor at MIT, where I lead the clinical machine learning group. I'm also the CEO of a new startup, which is using large language models to solve a lot of the problems we'll talk about today.
Excellent. Okay, everyone. So I think, so we've kind of assembled a bit of a dream team here, and across the spectrum, and I think there clearly is a spectrum. I think what's so interesting about this field is that and I hope the professors here would agree, the translation time here from things in research to papers to products seems extraordinarily fast, certainly compared to healthcare. Maybe that shouldn't be the standard that these things are compared to, but it's I guess, yeah, we're just kind of let me just start with Nikhil, if you don't mind. You kind of mentioned frameworks, and I know there's a number of people here, obviously given the backgrounds of the people tuning in, like a framework to think through the applications of AI in healthcare, and also maybe kind of extending that to large language models. Sure. So do you mind if we start there, and then we'll kind of move forwards? Sure, we can. So, and obviously this is not rocket science, and it's not artificial intelligence level science as well. But one of the first things that a partner of mine, Dr. Mark Harrington, and I thought about several years ago was, well, let's not think about AI just purely in how a provider might use it. But if you really think about applications in healthcare, you think about who the user is, and it could be anyone from the patient to the provider, to, let's say, a population health manager or a public health person, or someone doing R&D or administration. And in fact, I think LLMs cause us to add one more to that list, which is just medical education. And in every one of those cases, there are distinct applications, whether it is on the measurement side, something like diagnosis, if it's care delivery, or it is on the decision side, so decision support, or even the actual delivery of whatever that is, whether it's patient engagement through a chatbot, or delivery of medication through a closed loop system, a glucose pump and monitor. So I think the way I would sort of urge this group to think about this is to think broadly, and let's talk broadly about use cases in healthcare, not just from a provider perspective. Okay. Okay. Gaurav, and then Emily, if you don't mind. Gaurav, I know based on previous conversations that we've had, sort of a leading question here, but you've spent some time, and also you kind of teased it a little bit on in our last conversation about some frameworks to think through applications of large language models here.
Yeah, I love frameworks, as anybody who knows, who's worked with me knows. I like what Nikhil said, right? The provider angle here is only a piece of the puzzle. I'll dive a little bit into the provider angle, partly because it's fresh for me. I was just on service earlier this month, and there were probably a dozen occasions where saw a patient for whom I wish that this technology were sort of ready for the healthcare world already. And had a lot of trainees on my service as well, and started to think about what does it look like to think about what any of these technologies could do in the way we might think of a medical student or an intern on the team. And so I'll tell you what I mean by that, right? Oftentimes you have a trainee sort of take the first history and physical of a new patient who comes in the door, or someone who's been transferred from another hospital, and they go through the stack of medical records that came with that patient, or someone who's been in the healthcare system for decades, right? And has decades of notes. We had a patient who came in with a very complicated bleeding disorder combined with a clotting disorder, and figuring out what to do with that patient is actually quite complicated. And the history matters a lot. And so I thought about what actually happened when we were in the clinical setting. Well, a trainee, often the intern on the service, maybe a resident, went through those notes as best they could, surfaced a summary, presented it, and as the attending on the service, I sort of took it at face value, right? And it's not that I haven't been burned in the past, right? That when I do go back and look, that I find something different, or I find something new, and that sort of changes the conversation. So I was trying to map that experience and that thought process to what I might do if these technologies were live today. And the sort of high level way I thought about it is there's an evolution of trust, right? That goes from you don't trust at all, right? So someone tells you something, an intern tells you something, they haven't earned your trust, and you just recapitulate everything, right? There's a trust but verify sort of mode that maybe is a step beyond that. There's a trust but selectively verify, which is, okay, I take most of this at face value. These two things are super important, and so I'm going to validate those myself, right? Because they're sort of binary sort of branch points in the decision tree. Or I trust so much that I don't even need to verify, right? And I was reflecting on our last conversation where it was sort of pre-reference and sort of cite your work and explain your sort of chain of reasoning experiments. And I was in the either don't trust or trust but verify everything mode, right? And since then, what I've seen, Trishan, you alluded to the evolution of the technology even in the last month, which is stunning, right? I think all of us should take a moment and acknowledge how stunning it is that a month later, we're having almost a completely different conversation. But I feel like now I'm in the trust but verify, and that's being handed to me on a plate, which is here are all my sources, or trust but selectively verify, where we may be reaching a point where I actually take most of this on its face, and only need to verify the select components that are really important. So that's sort of one framework that occurred to me, and as the conversation progresses, happy to cite some specific examples of where just practically, I wish this were live, 2 weeks ago when I was on service. I'll just say one other thing and then hand it over. I'm sure other people have comments, but I was also thinking about, to the extent that one thinks about taking data and processing it for a user, right? And using the technology for that purpose, which is one subset of use cases. It feels to me in medicine, there's at least two different data pools to think about. There's data relating to the patient, which is this person's entire medical history. And then there's all of the sort of corpus of medical knowledge that exists outside of that patient. Think like what UpToDate and PubMed sort of encapsulate. And to me, it feels like one could think about use cases for content summarization, transformation, application in each of those two pools separately. So what are all the things, if this thing could read the entire medical record like an intern might, and allow me to ask questions of it or present summaries, what are all the things I would do with that as a physician? And again, by sort of extension, if they read all of PubMed and all of UpToDate, what would I use that technology for? And then what are the intersection between those two things? So that's another approach that's been floating around in my head as a way to think about, again, a subset of applications, as Nikhil pointed out, clinical applications by a provider in the context of patient care, which again is a very narrow set of applications. But even within that, you could probably brainstorm several dozen applications off the cuff, which I think is also a stunning acknowledgement of the power of what we're seeing unfold here. So I'll stop there. Lots more to talk about.
Very cool. Thanks, Nikhil. Thank you. Okay, so a number of different follow-up questions, but I think I'm gonna just want to get everyone in the conversation first. So Emily, if you don't mind. So I mean, I think from from what from what Gaura's been saying here, we have, kind of by implication, he talked about a way of looking at it, but by implication, there's a number of opportunities, right? Stated.
It's interesting. One of the frameworks, and maybe I'm saying it in a much more simple way, is like even your example. Are you looking at this source as like a trusted thought partner? Like I put it in and it refines my thinking. Like I would go and talk to a really good other doctor. Yeah. Or is it my, like, the person who's above me who I have to listen to and only question if I really see it? Or do I just put it in and believe it's actually true, right? Like I just follow it blindly. And that I think is the evolution that we are going to go through and how we think through that. And if we look honestly outside of LLM or other people believing blindly technology, that hasn't led us to a great place overall as a society. So trying to think through how we actually make those evolutions. But I also can think of a frame, which I won't say the company, that did do clinical studies that was looking at it from diagnosis basis, that was saying, here's our AI, here's using it as kind of the enhanced, let's help, in this case, radiologists look at this. And in the instances that the radiologist came back and made modifications, they were worse than the AI themselves. So there are some things where it's right or wrong answers that you can actually prove over time. I'm the investor. So I also have to overlay a different framework, which is like timing and business model and the go-to-market components of it. And we're all very excited, but let's be really frank. People are still talking about telehealth. Yeah. I don't even own a telephone, right? This is not an industry that is quickly adopting technologies and driving better outcomes for patients. And so thinking about where are those wedges that you can enter into to be able to have these technologies have a real input. I have sat at so many, like Suchi, I'm not on the academic side, but I have been making investments in the space for over a decade. I have companies that were de novo applications for diagnosis and regular AI modalities that are just now coming to market and are still facing like people trying to understand it. So we get very excited about where it could go, but I think for us to really have impacts that will drive real change in the ecosystem, we have to think about how you actually align the incentives in this really messy, complex environment with some pretty large players that have mediocre data sets that are going to be very, that are not going to open us with like open arms and embrace it, as well as a regulatory framework, payer framework and regulatory framework. And so one of the things I always think about is like the 5 Ps, right? The payers, the providers, which is health systems or in this case, value-based care providers, we're seeing a lot of those. Practitioners, which aren't always the same as the health systems, honestly, can be very conflicted. Patients, and then pharma or the diagnosis side, right? And most of my best companies or companies that are able to figure out ways of going to market are finding incentive alignment across 2 or 3 of those, right? And so I think you have to think about not just what is the cool thing or putting it in a paper showing the outcomes, it's who using it, how does it get paid, and how do we effectively bring that to market? And that is where I think there's going to be, as much as there's amazing technology, that I think where there's going to be the most challenges in the next decade. And Suchi is smiling because she actually has figured out some of this, but it is really hard. And I think you have to be in the ecosystem to understand that you have to move slowly in order to move quickly.
Indeed. Okay. So I mean, we're not all here by coincidence, right? Like, I can't think of 2 more thoughtful people to follow up here than Suchi and David, and I'll let them talk about their work. And I think the reasons will be obvious. So Suchi, maybe you first, if you don't mind, response.
Yeah, absolutely. I just wanted to say, I feel like, Emily, some of the work you've done has been absolutely fabulous in this space. And I actually think the question you brought up about really truly understanding the bigger stakeholder system and the problems they have and how you bring them together to think about how the technology is going to create value is probably the hardest part. And I think, interestingly, technologists often start with the technology and the fascination with the technology, but and they forget about the problem. And when I started in machine learning almost 20 years ago, got into the field super, super early, trained with some of the superstars. I've had a front row seat in the field as the field has grown, and got into healthcare only in 2007-8, just around the time when, Stanford was just starting to implement Cerner and Epic, pre-HITECH Act, we're just starting to see electronic health records. I think people in machine learning AI didn't think about EHR, the word health record was like, what is that? And people in health records or medicine, I think we're just still new to health records. And so certainly I've had a chance to see Gen 1 of companies and Gen 2 of companies, and plays that were very early. I remember back in 2008-9, we were working on, we got this Moonshot Project grant to work on modeling, developing techniques for modeling babies, neonates at risk for complications. And seeing like, could you predict which babies at risk for massive complications? Because preterm, preemies are especially at risk in the first month post-birth, and for both mortality or neurodevelopmental delays if you don't tackle complications in a timely way. It was super fascinating to see how we could take that data and actually identify which babies were at risk. But going from there to bringing it to market was a whole another ballgame. And this is back in 2010, 2011, when we were starting to see these results. And it felt like, we needed to have the technology infrastructure layer, just the ability to have, most systems didn't have EMRs in place, right? The thing that's been exciting the last few years, we have EMRs now. We have the ability to leverage it as infrastructure. So now there's actually digital data flowing. The no information blocking rules has made it possible for information to flow. Trishan, you've done firsthand work in using this data in really productive ways for payers. Then building value-added services on top. And then last year, CMS for the first time, approved billing codes for fully autonomous AI devices. FDA released guidance on wanting to expand oversight for multimodal AI. Congress passed legislation in December for wanting to see, for reforming the way FDA does oversight. So in a year, we're seeing so much massive movement in the market. And I think just a lot to hold in your head as, the technology, the business side, the go-to-market side, the integration side, and it's a small, small world, right? Trust is the number one thing in this market. Like, I think everybody knows everybody. So you can't be in a situation where you do things, so your reputation is everything. So you have to figure out a way to do things that is, don't, do things fast, but don't break things. Be very mindful. Real lives are at stake. So just do the right thing. And, integrity and culture is really important. Having said that, I'll say 2 minutes about the company very quickly. What Bayesian does, like I said, it's a platform that sits like a sleeve on top of the EMR, pulls data in real time, provides a point of care augmentation for care teams. The problem being, 1 in 3 staff are leaving the workforce. We have staffing shortages. Patients are only more complex. There's now all this multimodal data. There's enormous opportunity to create value, both clinically, financially, and through alignment between multiple stakeholders. And so what Bayesian's doing is providing point of care, augmentation in a number of different clinical and clinical operational areas.
Suchi, thank you so much. I mean, thank you also, Emily. I mean, I think, so in that response, right, Suchi, I'd like to call out a little bit of what you're doing in Bayesian as well, because I think it's important to kind of also move the discussion forward. So, Emily spoke about, we can't just focus on the kind of technical R&D, I suppose, the tools, so to speak, but then there's also the importance of incentive engineering and also regulatory alignment. But then you also implied there, and I think I want to call it out because it's incredible work, doing the evaluation in a very kind of thoughtful and, maybe to use the word in an alternative sense, multimodal way. Would you mind just talking about that quickly and just before we move on to David, if David doesn't mind?
Yeah, absolutely. So one of the big gaps I've seen in the field in the last 5-10 years as the field has evolved is, I think a lot of, if you look at the field of AI and health AI, there are a number of groups around the country publishing ideas saying what I call feasibility. Like they take some data set and then they show like something that can be done. So you go in a lab, you take some data and you show it can be done. So it can be done here, it can be done there. And the way the can be done is you're taking a huge amount of retrospective data and showing AI's ability to identify something early, or to detect something, or to segment something, or to give you some intuition. Then there's sort of this little bit of a chasm between the can be done to is actually clinical grade, medical grade. I think this is where in radiology, we've seen early companies led by really fabulous peer founders who've gone and they've, they were Gen 2 founders. They went in and they actually, went through all the process of what it takes to get adoption, which is integration, evaluation, rigorously understanding who this, productizing it. Who is my user? What are they doing? What is their pain point? What pain points am I solving? How can I measure that I'm actually doing that? And then what is the scale model? And so going back to Bayesian, a thing we noticed is basically, historically, there's been no real world applications where people have shown prospective evaluations of multimodal AI. And what Bayesian did was in sepsis, it's a near and dear condition by heart. I've worked on it for almost 8 to 9 years now, wrote one of the early papers in the field, and which almost was back in 2015. And going from there, talk about bringing from idea to the bedside. It took us like almost 8.5 years to do this piece of work, but we did this. The question people would ask is, yeah, you can detect sepsis early. We know it's one of the most promising avenues for improving sepsis outcomes is early detection and timely treatment. The question is, even if you could show that it could detect early, will providers adopt? Furthermore, there have been other groups that have done pockets of studies here and there where they hadn't been able to get provider adoption. They basically implemented some tool and essentially got nowhere. It didn't get any adoption. There are a huge number of reasons why that can happen. And so my focus shifted on not just the feasibility, but how do we think about real world adoption and drive, because ultimately you can have best technology in the world, but if you don't get real world adoption, you're not going to get outcomes. So step 2 was real world adoption. And step 3 was evaluating to build trust. Trust for scale, you need trust, and trust will come from data. And in medicine, in every other aspect of medicine, we believe in the notion of trials, even if they're pragmatic. But in digital health, we've lost that. We sort of feel like, from tech, we go into a room, we make up a slide, we start marketing the slide. Ultimately, you're using that to do sales. There's no peer-reviewed publications. There's no notion of what's the study do? Does it really work? And so for us, we released these 3 studies last year, which was on the cover of Nature Medicine. It was really monumental amount of heroic work from a team of 17 to 18 co-authors, clinicians, quality improvement experts, human factors engineers, machine learning people, data scientists. And what the study showed was, on very large cohort, it was academic and community hospitals, 5 different sites. This was hospitals that was part of the Hopkins enterprise. And over a 2.5-year period, 4,400 clinicians who were part of it, and nearly 89% adoption, which means when Bayesian would flag a patient, providers would go in, look at the results, and then enter an evaluation. Furthermore, we had already shown it had lead time, early detection. We were then also able to look at outcomes like mortality, morbidity, length of stay, and a number of other things. We also studied what factors led to adoption, and that was fascinating because it helps the field and us understand, sort of build confidence, not just sort of the fact we got it, but it's the reproducible results. And we did a ton of work in understanding how to build a system in a way that builds trust. And so designing for trust is so important that I think is often overlooked.
Okay, thank you, Suchi. Thank you. Thank you so much. So, okay, so we've kind of discussed, I think everyone has discussed the centrality of trust. Suchi's just expanded on that with this incredibly well thought out way of how you actually engender that trust in a new technology, particularly one which is essentially a probabilistic system in enterprise healthcare organizations working with physiologically frail patients. And that's very much the state of the art. I think moving into the overall theme of this discussion is large language models. And David has done a lot of the foundational work here in large language models in healthcare, and then is productizing that and dealing with a number of these different issues at the moment that we've discussed: the incentive alignment, the regulatory alignment, the evaluation, and how to do that in a thoughtful way. David, would you mind kind of sharing a little bit about kind of what it is you do and this transition from the academic work into MedNotes?
Yeah, sure. I agree with everything Suchi and Emily and Gaurav said so far. I think it might be helpful to tell a little bit about sort of the research perspective, putting my hat on as an MIT professor, and then where I see things going from a commercialization perspective. So on the research perspective, maybe we can think about just one example of the use of large language models. One that Gaurav already referred to in the beginning of this, that of summarization. So imagine that you have a new patient walking in and your clinical team wants to better understand that patient's past medical history so that it can inform the workup and next best steps of today. One might imagine saying, okay, let's take the patient's past medical history and asking a large language model to generate a summary about that can help the team better understand what's going on with the patient. But the first thing I want us to think about is, well, what is a summary, and is there such thing as a single right summary? And I'd argue that there isn't such thing as a single summary, and it depends very much on the use case and the particular clinical setting that one wants to tackle. So let's dive into a slightly more narrow use case. Imagine that you are an oncologist and you are a recurring patient, a patient who you've been helping treat for the past few years or last year, walks into your office for a new visit. And you want to understand, well, what happened between the last visit and my current visit? So you want to look at perhaps the past progress note that you wrote. You'd want to look at notes that the primary care physician might have written. If the patient has cardiac issues, it might be interesting to see what's going on from the perspective of the cardiologist, recent imaging, pathology results to get a sense of progression of the cancer and so on. And all of that you might then summarize in the context of the assessment of how the patient is doing, and that would inform then your plan. And some part of that summary would show up in your assessment plan part of the note itself. And so one might ask then, okay, how do we create a summary for that specific purpose, that specific use case? If you think about other use cases, so perhaps a patient goes home from that visit and you say, okay, what is a summary for that patient? What is a summary of that visit for the patient's primary care doctor? Each of these will have very different needs. And so from a research perspective, one of the things that at MIT we're very interested in studying is how can we help domain experts build good mental models of the system, and it could be an AI-based system like a large language model or something else, of what the system is likely to output. And so we've spoken about how one could try to provide evidence for conclusions. So if you ask about diagnostic workup, or if you ask about the current medical guidelines, you can imagine answers all having links to up-to-date and other resources that support that fact. But if you think about the summarization question that I just raised, well, what is the evidence for what wasn't written in the summary? How do you help the domain expert, the clinician in this case, have confidence that we're not missing something in what we're outputting in the summary, that we haven't done the synthesis incorrectly, and so on? And I think that's a really important research question, which we're studying at MIT, and many other folks are studying as well, that really human AI interaction question of really what is the right both experience and checks and balances one could put into that process in order to have safe and effective deployments. So that's really from the research perspective. If one now moves a little bit towards commercialization, I think the things that have been mentioned so far about how do we get where is there alignment across stakeholders and where is there short-term and then long-term revenue potential are really the things that are front of mind for me. And so if I go to some of the things that we're working on at MIT and try to answer those questions for them, you'll see very different answers. So one of the things that we're really excited about is how can we help patients better understand their notes? So continuing with that oncology example, a patient comes home from a visit with their oncologist, and they get a note with a ton of acronyms relating to genomic markers that they've never heard of, medications and treatment plans whose names they don't remember from the previous visit. And the question is, well, how can we help that patient both understand what just happened to that visit? They might have already forgotten the follow-up action items, for example, that were discussed. And how can we help empower them to be more proactive in their care, while at the same time not leading to what I think many clinicians are concerned about, which is an even worse version of Dr. Google. Mm-hmm. And so there, one could imagine building augmentations for the patient, such as maybe a translation of the patient note into a form which is easier for patients to understand. One could imagine taking that note and inputting it into a GPT-4-like model and asking, what are questions that the patient might want to ask their provider based on this note. In fact, that works really well. You get some really interesting questions that I think could really help the patient with the following up on both their own research and in their communication with their care team. But as powerful as I think that research direction is, and as much I think ongoing work has to be done about how to do that safely, I don't know of a good business model to bring that to market. And so that, for example, is not something that I'm currently working on, as much as I'd really love to work on that. You can contrast that, for example, to something else. We wrote a paper a few months ago in a natural language processing conference called EMNLP. The lead author was Monica Agarwal, which looked at how one could use large language models for extracting information from clinical notes. So you have a note, it has a lot of jargon, and if you think about the future of real-world data, how could one extract from a patient's longitudinal journey, which includes both structured and unstructured data, information about what actually happened to that patient, what are their outcomes, and what were their patient's comorbidities, and what were aspects about them, included things like socioeconomic factors that would actually affect the treatment decisions and those outcomes. And one needs that longitudinal structured data in order to do any comparative effectiveness study, in order to power the future of precision medicine, for example, build machine learning models to predict who is likely to respond to which treatment. But most of that information is really hidden in clinical notes. And so what we showed in that paper is that these large language models are extremely successful at extracting discrete elements from clinical notes much better than anything the machine learning field had been working on up until now. And that is something that I think I can monetize in the short term. And so I just thought that would be a useful contrast as we think through the business perspective. And that's what our company is working on.
Can I ask a question?
Please, Emily, go for it.
Sorry, because so much of this, all of this is an enabling technology, right? So it's only as good as the data you put in. So I'm really bad data in, crap out. So when we talk about this, not only how do you think about that application, but how do you think about data integrity and ensuring that the data that you're using is the right data? Because that's the other piece that we're not spending enough time on, and you guys are in the field. But to me, having looked at some of even my own notes in EHRs, it's not pretty, right?
David?
Yeah, I think that's exactly the right question to be asking. So if you take the naive short-term perspective of, well, we can only work with the data that exists today, we can change the data that exists tomorrow. Then from that perspective, I think one of the relevant questions is how can we provide the right evidence for each one of the conclusions that we might draw? And that evidence generation, I think, is going to be a really important part of any product that one builds in this space. That said, we need not stop there. And another component that I'm very excited about that we've done research on, we have pilots used for several thousands of patients already, and we would like to commercialize as part of our startup, is about changing the data entry from the very beginning. So one of those research studies that we deployed at Beth Israel Deaconess Medical Center in the emergency department was to do an AI-guided documentation process. So here clinicians are writing their notes. In this case, might imagine typing, but we can talk about other modalities like speech recognition as well. And our AI algorithms have, given the context of the patient's past medical history and the partial note that's been written up until now, we can reason about what's going on with the patient and what the clinician might be needing to and wanting to document in the future, and then gently guide them, very much similar to the way that we write a text message or Gmail, you have autocomplete. Gently guide them to enter in information that we really want to be entered in, both increasing the quality of the data and at the same time decreasing physician burden due to decreasing the time to data entry. And with that said, a very important question that all of us should wonder if you're doing that is how you don't increase data bias, errors, and related questions once you're in that loop. And I'm happy to talk about that as well, because it's a very important question.
Yeah, I mean, there's a few very important things being mentioned here, folks. So, I mean, this is hugely inspiring work. I think I just want to just reflect on a few points here. One is that the reason we're kind of set it up in this way is that the foundational models are advancing so fast, and I think you'll all have seen that in the popular media, and certainly we've alluded to some of those things here. But there's so much stuff that has to be done still, and we've got two. It's very unusual to have world-class professor, world-class entrepreneurs together in the same person, and we got two of them here, and you kind of hear how they're thinking about it. And this is all of the work that needs to be done to actually kind of realize the value of this kind of thing at scale, exactly as Emily highlights. But there's a few really important points here. One is the state of the art around the evaluation of technology, particularly in physiologically frail patients at the front lines of care, as Suchi detailed. And then what David's described here is this thing of knowing a patient, knowing your own patient, knowing what's gone on in the past, how that informs what's going on at the moment. There was really only in it was clinicians and groups of clinicians who had that, and even arguably not even groups. There was a kind of, that was one of the underpinnings of the importance of longitudinal care. We have a kind of a viable alternative now. I mean, it's early, but certainly what David, and then if you expand that to scale, this concept of like the learning healthcare system, which Institute of Medicine, many others have been talking about for years, but not being able to operationalize beyond developing the data substrate, which of course is the essential foundation. We have a viable path there as well. It's incredibly exciting. I think we are also, unfortunately, the laws of physics remain in place. So we do have a bit of a time pressure. But I would like to just quickly, kind of lightning round, I think everyone who's watching this has seen the stuff in the press and is seeing some space age type results and a whole kind of space age, maybe the wrong word, but some futuristic results and a whole load of hype around GPT-4, what Google are coming up with these foundational models. I think if we wouldn't mind just kind of going backwards through the group, how much of that stuff is real? Are these really foundational advances that we're seeing for the benefit of the audience? David, do you mind if I start with you, or just kind of go backwards in order, I suppose?
Yeah, I mean, yes, I'd say I think it is real.
Okay.
What really excites me are two things which I think are complementary and demonstrate the value. The first is an ability to really understand language at a much deeper level than had ever been possible before. And the second is an implicit knowledge base that we now have access to via potentially HIPAA compliant means. And for that latter point, the impact, I think, is going to be far beyond just language modalities. So for example, at MIT, we wrote a paper last year which looked at how one could do prediction from health insurance claims. So you have a longitudinal record of patients' procedures, diagnoses as encoded in diagnosis codes, laboratory test results, and so on across time for patients. And you might ask, okay, well, what's going to happen to this patient in the future? If they were recently hospitalized, how long until they're rehospitalized? If they have kidney disease, how long until dialysis? If they have a rare disease condition, what is their future life going to look like? And as one wants to, if one were to think about doing prediction from that side with data, which is not language at all, one could actually show that one can rewrite that data in a form that it looks like language so that you can input it into a large language model like GPT-3 or 4 and make predictions based on that. So what that would allow you to do is really to pull into the implicit knowledge base that's part of these large language models of medicine and use that to make predictions at particularly for rare conditions at a way which we had never been possible to do before. And I find that is very, very powerful as well.
Sure. Okay. Well, okay. I don't want to ask questions, so I'm just going to move directly to Suchi, if you don't mind. Oh, Suchi, we're on mute. Sorry.
Sorry about that. A very common misunderstanding I'm seeing, outside of academia, so first of all, the results, your direct question, yeah, the results are real. There's a lot of exciting work happening. It's breathtaking. It's not just sort of the chatbot, there's just across the board. I want to unbundle things a tiny bit, because I think when we get to study AI and develop AI, we get to think of it more ground up, right? More foundationally, what is the technology? What are the components? How do they come together? I think a common thing that I've been frequently surprised by when I'm interacting with non-experts is sort of this, is it a box? Like, is ChatGPT now this one box and this box can do amazing things? And then are we just sort of looking for yet another next box? And to me, it's not just the fact that this box is interesting. It's really like all the foundational technologies that led to that box. So the technologies that led to the box are several, right? It's our ability to train models on complex multimodal data. It's our ability to learn from really messy real world data. It's our ability to do real-time human feedback, something that we've been exploring for the last, like a lot of reason why we were able to succeed and get very far was from real-time feedback from like what providers are doing, watching that and then learning over time, right? Like RLHF is what it's called. But like when you unbundle, there are 6-7 streams of underlying pieces of work, each now that push the, our capability layer forward. And then the thing I think that's very important for the field to think about is then what Emily said, how do you bring these together in the context of a problem that you deeply understand and know how to solve, and do all the relevant validations necessary to make it happen? So if you try to do too much, where you're like, trying to make the smartest thing, you're going to have to validate. It's very good at 10,000 things. That's quite expensive and hard to do. So can you find the things that you want it to do and then do the desired level of validation? And you can compose the solutions by bringing these building blocks together. So it's more like Lego rather than one toy.
Excellent. Okay, thanks, Suchi. Gaurav?
I'll defer to the computer science experts on if it's real or not. It certainly feels real to me. The comment I'll make is, I think the whole practice of medicine has been structured around what humans can and can't do. And so if I think about like the impact piece, I think the impact will be absolutely transformative. And I'll just give one quick example, which is, early on in my training to assess sort of stroke risk in atrial fibrillation, we use the CHAD score. Many of you are probably familiar with this, which was a score of like, add 1 point for X, Y, and Z, right? And these are 5 things, and they're reasonably easy to assess. And why did we use that score? Even years into better scores being developed that we knew were more accurate, right? This was easy to remember and easy to execute, right? So this is, it's an example of where medicine, the practice of medicine followed sort of the practicalities of being a human physician, right? And now you see, as Suchi pointed out, the rise of EMRs, the embedding of different capabilities, et cetera. The residents now use smart phrases in Epic that calculate scores in a note, right? So, okay, once you can do that, now it doesn't matter how complicated the calculus is, right? Behind the scenes, I need to calculate prediction score X. If it's a better score, I just use that smart phrase, right? It's equivalent amount of work for me. And so you've pushed the practice of medicine forward by basically overcoming what was fundamentally a structural barrier of what humans could do in their head, right? When I see some of the early work with, especially the latest instantiation of this, the expansion of token sizes, inputs, et cetera, you start to think about a system that can hold in its head far more than a human can, right? It can read the entire history of a patient and use that at once, as opposed to, as a doc, what do? I read the last handful of notes. I try to keep as much of that in my head as possible and then reason against that, right? So to me, it just feels like this is a fundamental shift in how medicine should be practiced, because you take, again, the structural limitations of human capability and you say, okay, what would be different if those weren't limitations anymore, like we did with risk scores? And now you might, when you get to that point, you have to actually rethink how you practice medicine, right? The physician now starts asking questions of the system instead of asking questions of themselves. And the rest of the practice can be the same, but now you're asking the system, what's the latest evidence of this, or what's the history of this, or why did this person end up on this medicine, or whatever. And suddenly your ability to reason is superpowered by sort of bottomless information processing ability. So for me, it feels like as long as the technology is real, David and Suchi have said it's real, so I take that at sort of as proof for me. And then, what are the implications? I think the implications are absolutely transformative.
I totally agree. I think general kind of like bow around that, like, if your clinician is the pilot, there clearly it makes, would you not want your clinician to have like a superhuman co-pilot? I think the argument's probably yes. Nikhil, so I mean, impact on your clients, but also on professional services, which you're in, right?
Yeah,
so quite profound here.
So very quickly, I love David's example about equipping the patient when they go home, because I cheated this morning. I asked ChatGPT to give me 100 use cases for LLMs in healthcare, and that was the first one. So, but Suchi, you pointed out how hard it is for adoption, to get adoption. And in some senses, that's the first case to actually create value. And Emily talked about that as well. But that's not enough, because you've got all the risk aversion around use, but you also got risk aversion around the buyers for all sorts of good reasons. And so creating value is not enough. It's about how do you capture that value and what's the business model around that. And so that's what I tend to work primarily on my clients with. You also talked about how the FDA, CMS, and others are, in some senses, removing some of the structural frictions that existed around billing codes, et cetera. And so to me, that's the really exciting place, is to see, can we, right at the start, while thinking about the use case and how to put the technology to action, that we're not just thinking about how that technology is going to work and potentially add value at the point it's being used, but also, in order to be sustainable, what is the way in which the innovator can capture some of that value?
Yeah, thank you so much. And Emily?
Yeah, and this has been fascinating, and I'm so honored to be here. Well, I just building off some of the things, particularly that David was saying, made me think. I do think there's a lot of opportunity, but one of the things in the back of my head, these technologies, are you optimizing a flawed system? Or are you actually creating a new system because of the capabilities of the technology? And that, I think, is going to be, honestly, the most profound thing we have to figure out here in pretty short order. And there's a number of things. I mean, the existing, what Gaurav was describing, like, our system is predicated upon interventions. Once you are sick, they can go and then do a clinical pathway. We're really bad at preventing you to get sick. We have no codes. We're really not figured out. That's what's really killing most of us, right? But the entire modern medicine is, if you get in a car accident or you need surgery or something like that, we're really good at it. When it's chronic diseases or managing this, we're not very good at it. And that's because this is all about breaking us up into very specific body parts or cuts or things that can be billed, versus actually thinking about what we truly are, which is this extremely complex system. That is where LLMs should thrive, right? Understanding there's interconnectedness and that, but like, how do we actually overlay economic models and adoption models that actually make sense for that? And so that, to me, is like, it's not what you're talking about, like changing the input models, how we actually move to value-based care, other kind of modalities, because if we're just layering this technology on our existing system, we'll bring up some of the worst players, but we're not actually doing what we really need to do, which is change the cost curve and actually improve care. We have a massive crisis, both from a cost perspective, from a provider burnout perspective. And so I'm just worried that layering this on and saying, like, it'll be your savior, versus really rethinking how you actually deliver care because we have these capabilities, that's where I want to focus.
Yeah. Thank you, Emily. I mean, that's an excellent point to finish this side of it. Okay, folks, so we're kind of at the top of time, but we have questions, and the panelists have graciously agreed to go on for a few more minutes more, and Nikki's going to kind of ask some of those questions that you've asked. We won't obviously get to all of them. All of this will be recorded as well. So I want to pass over to Nikki in a second. There may be, I've heard from the panelists, plumbers, children, wild animals in the background, because we've just gone into their private time here. So if that's the case, I'm sure you'll all forgive us and thank them for offering a little bit more time. So Nikki, over to you.
Thanks, Trishan, and thanks to the panel. Agreed. We'll just go a few minutes and answer a few questions, and then Trishan will cut and follow up. But everything will be available, as we've mentioned, materials recording. Maybe Nikhil, we'll start with you. And I know, Emily, we talked about recreating the model, but at the moment, given today, we're talking about adoption and implementation. I want to focus on one question around how health insurance sort of carriers, payers can help these models to succeed, because currently such a critical player as we look to adoption. So Nikhil, maybe start to you with that question.
Sure, it's a great question, and could take up a fair amount of time, but given the limits of time, I'll give a very quick, short answer. And that comes back to the idea of incentives. And so being open to the idea that some of these interventions create value in a very different way from the traditional model of physician time or provider time. And so thinking about codes or ways of reimbursing these that are not tied to those previous metrics. So for example, if your previous metric was based on, I'm going to reimburse you based on how much time I think it's going to take a physician to do something, and now the AI can do it in 1 second, you can't translate your reimbursement value to that, because then the innovator gets nothing out of it. So that would be my quick short take.
That's great. Thank you. And I won't have others weigh in just for now. I think another question that's important is around health systems, okay, to drive adoption. So one question is around, where is there best practices around evaluating and implementing LLMs for discrete use cases? So I'm trying to think, is there someone who'd like to jump in on that one?
I'm happy to take a step.
Emily, why don't you go? Because Gaurav, I've got a special one coming up for you.
Oh, no, I was saying Suchi's the expert because she's done
it. Suchi, okay. Suchi.
I think it doesn't really matter like whether you're doing LLMs or any other piece of technology. The way to think about this is you're just evaluating. Like, interestingly, people get too caught up in the specific color of the box. And ultimately, it's a piece of technology. And if you look at it the way, regulatory bodies think about it, right? What is the intended use? What are you hoping to do with it? What is the risk you're going to impose on who the relevant population is, and what is your claim? What is it that you're going to do to bring benefit? Once you have all that sorted out, then you work backwards to then prove it, just like any other scientific hypothesis. You're just going to collect data to show if it's true. And you'll have to have the right set of comparator arms to compare against to make sure that you've, so the good news is we don't need to learn new rocket science technologies for evaluation. We only have to commit to caring about them.
Thank you. That's excellent. Appreciate that. So Gaurav, so your special question is, when you talked earlier, there are a couple of comments around where we actually set the bar around trusting the sort of outputs of LLM in healthcare. Other questions around what's the most important thing that we test as we think about their safety and effectiveness. So what's good enough here? How do we think about that?
Yeah, I think it's an excellent question. So 15 years ago, I worked on natural language processing technology for the healthcare system. And as you can imagine, it was a fraction of the capability that we're talking about today. And even then, we deployed it in the clinical setting. And so how was that possible? The key was we didn't expect it to give us answers. We expected it to source the records that were relevant for a question, right? So what do I mean by that? I'm looking for the history of this person's heart failure. Find me the first notes that mention heart failure. That's the thing that we can have the system do. We did validate the performance of those queries, but ultimately we were leaving the final decision up to the provider, doing essentially the same thing that they were doing before, which is looking at the notes. They were just surfacing the relevant notes. So if you take that example and extend it to today, to me, it feels like if we're in that trust framework of don't trust at all, trust sort of blindly, or in between trust with verification, to me, almost certainly we're going to be in the middle section for the foreseeable future. And so then the key to me is how do you verify, right? And that's where I would focus the energy, which is why I think the reference, sort of the ability to cite references that can be confirmed as accurate and then can be sort of reviewed as primary evidence, to me, that unlocks the ability to use the platform, because I'm just putting myself in the shoes of a provider seeing the results. I can read the results and quickly verify that it's correct. Then I can basically operate on it as if it were not even there, right? And so whatever sort of trust I had in my own ability and the accuracy of the record, et cetera, prior to the existence of the technology, you sort of mapped it back to that, right? But you've shortened the span of work in between. So my quick answer to a very complicated question is, if one could build confidence in the verification process and the reference process, the sort of show your work audit trail, et cetera, if you could solve that piece, I think these become ready for prime time use actually very soon. Versus like the things where you need it to run on its own, stuff that Suchi and others have spent a lot of time on, which is the randomized controlled trial using the traditional machine of evidence generation and validation. That's a much higher bar that I think you could probably get even nearer term wins. Again, if you had this sort of show your work and the ability to independently verify. And by the way, a lot of the medical device guidance follows similar principles, which Suchi knows quite well.
Perfect. Thank you. Okay, 2 more questions, one each for David and Emily. So we haven't talked much about the actual clinician who is offering these services, or at least we certainly have covered it, but specifically if you're thinking about the adoption piece by a clinician and knowing that there's just so much going on in that individual's day-to-day, and they're also dealing with patients who are not as familiar with some of these technologies and tools, not that they have to be. David, this is your finger on the buzzer question around sort of how we continue to drive adoption for clinicians specifically and providers who may not be focused as much on the ROI. Efficiency is important, safety is important. I'll let you jump in.
Well, our design principle in both our academic and commercial work is to be as invisible as we possibly can, and to work with existing workflows as much as we can. And I recognize, Emily, your comment about, well, what would rethinking the full system be like? But you have to worry about adoption, and so that rethinking one can do in perhaps targeted areas where adoption is easier to start with. But getting out of the way is key, in my opinion.
Perfect. Thank you. Emily, so many things out there. It's all happening so fast. Literally, as we're on this call, things are changing. How are you evaluating different models and metrics as you're looking to success of these different groups? Anything that you can help advise sort of our business people as we're thinking of looking at these different models? What's important to you? What feels real? Where are you focusing?
Yeah, I mean, I think, first of all, I'm not evaluating the models underlying. You have a lot of experts here. You're thinking about the outputs and the actual products that are being brought to market. There's one thing that I think is really important. This goes to what Sushi said, that I think is like, this is technology adoption. If you look at EHRs, it was not just adopted because they needed it. It was incentivized based, meaningful use. And it was really just a couple of companies that did it. So you got this break and you put it in, and it was not the best breed technologies that won. It was the ones that had the best go-to-markets and basically, smothered the industry with it. Here, I think there's going to be another overlay, which is you can't just actually get out there and the go-to-market is not alone or sufficient. You actually do have to have those clinical data and outcomes. You are going to actually start to be held. Are you, delivering the best quality? There were a lot of different types of models out there. Just a lot of them were crap, right? And so that was like, and the people who took the time to actually do that. And so for me as an investor, this sounds odd, but the very first thing I look at is clinical outcomes, the North Star. Because if you are not putting that first and foremost, then you're going to make horrible mistakes. And at the end of the day, that is how you are going to be rewarded, is knowing that you were driving better clinical outcomes. But then you have to overlay and think, how do you actually come into this ecosystem? How do you actually get who to pay for it? And how is it incentivized? And honestly, sometimes it's bringing in players who weren't otherwise there, right? You just saw an announcement of Viz.ai, one of the companies that I've invested in. Stroke modality, moving into cardio, but also now working with pharma that is very interested in better understanding those. And so you can create new kind of ecosystems that take the existing workflows, as you were saying, David, but then allow us to actually think new monetization models and others that can optimize the way that care is delivered. So that's kind of the framework that I can look at it from a business perspective.
I like that. Thank you. Thanks, Emily. Over to you, Trishan, to sum us up. Okay, thanks, everyone. Okay, so firstly, I'd like to thank you all for staying on, especially the panelists. I appreciate we've gone over our welcome. So I guess just a few kind of housekeeping things. So there'll be, this is recorded, it'll be on YouTube. So some of you will be joining us from the future. Welcome, of course. And anyone who's seen this, who wants to see the recording, I guess the easiest thing to do is if you just contact Amelia if you contact Marielle or you contact Susan, they will have it. Or if you follow me or any of the panelists here on LinkedIn, we will post it once we get it. Also, there's some slides, which I am just going to shift back to sharing now quickly, which will be available as well afterwards. If you follow us, you'll get it. So I've just posted the framework that Nikhil alluded to from Recon that he went through as well, just as a kind of aid. We had a very simple kind of pipeline going on in the background that summarized the discussion. It's there in bullet points in 4 slides if you want it. There's some resources that have a number of the papers that have been alluded to during this conversation. I'll add some more afterwards when I get some time. And so thank you from Nikki, and thank you from me. Thank you to all of the amazing panelists who offered their time and were gracious enough to accept this very dubious AI treatment. But of course, it wouldn't be fair to do it to them and not to me. So here's me supposedly in 20 years' time with a pretty attractive mullet. And obviously, I'm not leaving Nikki out of this. And so this is Nikki, our Celtic queen, to sign you off. So thank you, everyone. Thanks so much for your time. Thanks to the panelists. Thanks for tuning in. Any questions that we didn't address, I apologize. That's just laws of physics, I'm afraid. And any questions you have in response, I guess we're all on LinkedIn and Twitter and other kind of social things. So please feel free to find us there. Thanks very much.